Hi, everyone. Welcome to your first mini lecture of the day. I hope that these mini lectures are helpful to revisit the concepts because some concepts we've done earlier in the semester, and it will help you while you are diving into your simulations. So I hope you find these meaningful. We're going to dive into our first lecture, which corresponds with our first um, it corresponds with our first simulation of the day. Um, so for us, we're going to talk about acute ischemic stroke. This is going back all the way to week 1, where we talked about neurologic concepts. And the whole point of these little micro lectures are that we can review the concept before you go in and provide patient care, just so that you have all the tools you need to provide good care to these simulated patients. So, what is the big picture? What's happening with your patient and why does it matter? So, let's talk about ischemic strokes. Ischemic stroke is a sudden loss of blood flow to part of the brain. Neurons die within minutes of that shunted blood flow. So, when you can't get blood to the parts of your brain, you really can't get oxygen. And the brain needs two things: it needs glucose and it needs oxygen to survive. So, if we prevent the glucose and the oxygen from getting where it needs to be, we are really start to lose parts of the brain. So, recognition and time drive every decision because time is brain. Remember, anytime you're talking about a stroke, remember that saying, time is brain. So why does that matter for nursing? It seems like stroke can be a concept that the doctors deal with, but nursing, it matters because we spend so much time with the patients, right? So the faster perfusion is restored, the more brain tissue is saved. But how do we identify when perfusion has been blocked? um, Rapid recognition. So nursing care centers on that rapid recognition, and how we do that is through our assessments. Protecting the airway, again, assessments, those ABCs, and preventing complications while the treatment window is open. The treatment window is key for stroke patients. So our key concepts to review is that we are going to focus in on the neurosystem. We're going to do a focused neuro exam, and the concepts that we're going to really look at are the level of consciousness, an NIH stroke scale. It's a tool developed by the NIH, the National Institute for Health, and it helps us identify the severity of a stroke. But you have to be certified in that stroke scale in order to use it. So generally we use the GCS, the Glasgow Coma Scale. We're going to look at pupils, and then we're going to use the FAST screen. FAST is facial droop, arm drift, speech, and time. The time piece brings us over to priority. We have to establish the last known well and then protect the airway, and those items are going to come first. The last known well is super key because it helps determine if we can give life-saving TNK, that clot-busting medication, tenecteplase or alteplase. Generally, now the evidence-based practice is that we give tenecteplase. Or if the patient can go for thrombectomy, that is really important, whether or not we can do those things. And then we move to protecting the airway. Obviously, protecting the airway comes first. That's the A of ABCs. So we always want to make sure that we're doing that. And then swallow screening. We want to make sure that the patient gets, before they get anything by mouth, they have a swallow screening that's done. This swallow screening is so important because strokes can impair the way that patients swallow, and it increases their risk of aspiration pneumonia, which can further complicate things. So you want to make sure that your patient can swallow after their stroke before you give them anything by mouth. And generally, the first line medications are all in tablet form. So make sure you do the swallow screen before you do anything by mouth. And then our interventions are going to be positioning. We want to give these patients aspiration and seizure precautions. Aspiration, we just talked about because their swallowing may be off. And seizures, When you start to irritate parts of the brain, the patient can have seizures. So you want to make sure that the patient is nice and safe and secure. You want to make sure that you have IV access so that you can give them the medications if they can't take anything by mouth. And then telemetry. You want the patient on the cardiac monitor because sometimes, most times, it's an underlying rhythm that's causing the clot, like AFib or aflutter. The quivering of the heart allows the blood to pool inside the vessel, and then it clots as it pools, and it pushes out a clot when it's that time to go. So we want to make sure that we have the patient on cardiac monitoring. And then that continuous neuro monitoring. Patients can get worse in the first 24 to 48 hours of their stroke. So if they don't have continuous neuro monitoring, then they are at risk for like another secondary stroke. And we want to make sure that we mitigate that. And then pharmacology. So the concept of the thrombolytics and their strict eligibility window. So up until the current clinical practice guidelines, the last known well to TNK or TPA was 4.5 hours. That's the maximum time. They have now increased it to 9 hours for those wake up strokes. So somebody who went to bed and woke up and now they have a new onset facial droop, we can give the TNK a little bit longer, but they have to meet certain criteria. So generally we're going to stick to that last known well till 4.5 hours to give that medication. But we want to make sure that our blood pressure parameters are met before treatment. So those blood pressure parameters are that the patient's blood pressure, the systolic blood pressure has to be under 180. We want to make sure that we maintain that before we give the TNK. So what's happening pathophysiology wise, right? The brain is getting irritated, and that is causing an increase in intracranial pressure, which is then driving that blood pressure up too. Okay. And then we want to make sure that we have some antiplatelet timing as well. All right. So how do our concepts connect, right? How do we trace the reasoning from problem to action? Because each idea leads to the next, right? So recognition. The neuro exam tells you that a stroke may be happening. They maybe have a new onset facial droop. They may have an arm drift. Maybe their speech is slurred, or maybe they only have a facial droop, but their arms are fine and their speech is good. All of those things. And then time, last Noel decides whether treatment is even possible. If the patient has a facial droop, arm drift, and speech problems, but they're outside of that 4.5 hour window, or in special cases, 9 hour window, we're not going to give the TNK. It's too much of a risk for hemorrhagic transformation, where now we went from a clot to a bleed. And then specifically with the thrombectomy, if it's been greater than 24 hours for these symptoms, we're not going to do the thrombectomy because, again, that risk of hemorrhagic transformation is so high. And then we want to maintain safety, right? We want to make sure that the patient is protecting their airway, and we want to give the patient the tools to not develop aspiration by doing that swallow screen early and getting those speech language pathologists involved if we need them. And then treatment. The patient has to meet the right eligibility, right? So again, that window of last known well, that helps our eligibility. Our NIH stroke scale, which you don't have to know, but that number has to go into it. And then blood pressure control, right? So if our systolic blood pressure is even 181, we can't give that medication until we've controlled that blood pressure. We're going to give some medications like nicardipine or labetalol to get that blood pressure down so that we can give the TNK. All right, nursing reminders. So you want to take this information into your simulation and your care of your patients in the future. You want to keep the patient NPO until the swallow screen is passed. If you do a swallow screen and the patient fails, it's better to get speech involved sooner than later. They're the experts. We just do a bedside swallow exam to help minimize the patient volume for them if we can. Neuro checks are only useful when done on a schedule compared over time. So when you think about giving TNK, right, your first 2 hours of your post administration is going to be Q 15-minute vitals and Q 15-minute neuro assessments, full neuro assessments every 15 minutes. And then after the first 2 hours, for the next 6 hours, you are going to assess every 30 minutes for 6 hours. The same thing, neuros and vitals. And then after that, you're going to move to hourly up until you reach 24 hours. So this patient needs a lot of care, total one-to-one care for the first 24 hours. So that is why these patients generally go to an ICU. You want to know the blood pressure parameters before any time-sensitive therapy. So again, remember that systolic has to be under 180. And then you want to give a clear, organized S bar because it helps move care faster than the drug ever will. Make sure that you say, the situation is here is that the patient has a new onset facial droop. They have arm drift. Their speech is slurred. They were, according to the family, 30 minutes ago, they were acting completely normal. And then all of a sudden they stopped in their tracks. And I looked at them and they had all this. So our last known well of 30 minutes ago. And our background is that maybe this patient has the risk factors for a stroke, right? Like maybe the patient has cancer and is undergoing treatment, or maybe the patient has carotid artery stenosis, or they have hypertension or hyperlipidemia. All of those things will be our background. Our assessment is that the patient has a gaze that's deviating. And our recommendation is that we need a doctor at the bedside right away so that we can give this life-saving medication. All right. So that's it for my stroke lecture. You're going to get a little bit of these lectures all day, and I hope that they're helpful. And if you need anything else, let us know.